Welcome. So my name's Nathan Peck. I want to welcome you to the 2026 VCP International Scientific and Community Summit. We're going to have a pretty full room today, but I hope that you've had a chance to meet others and see familiar faces. All right, I want to thank our sponsors. The AFTD, is Kim here? No? Okay, in transit, all right. And then the Muscular Dystrophy Association US, and then Ultragenics, as well as Muscular Dystrophy UK, and then North Star ALS. And I think North Star ALS, are you, okay, yep. And I think you'll have a table outside. We definitely want people to stop by and say hello and meet you. Thank you. And then the AFTD as well will have brochures and flyers. So please stop by and say hello to them as well. But thank you for your, we couldn't do this all alone, so we appreciate your support. All right, so let me start real quick. I'm going to try to breeze through this, but, how are we here today? So obviously I'm a VCP patient. This is my family. My Aunt Karen is here. You may have met her checking in. But my mom, 6 siblings, 4 out of the 6. It's a familiar story to a lot of people. Everybody's deceased now. My last uncle died back in November. But, through the 90s and 2000s, we had this curse in the family. We didn't know what it was until 2004 when Dr. Kimonis identified the VCP gene. And so in 2016, I was still working at the time, but Dr. Kimonis, with her first family, and she probably recognizes this picture, this was family number 1 that she studied. They had an event in Jacksonville, Illinois, about 2 hours outside St. Louis, for biocollection and samples, but also doing functional measures. And so I flew out from Georgia to go to that event. And some of you may recognize, I think Renee's in that picture, and Krista Tour, some other folks. Some other folks flew in. This is my first time meeting other families that had the disease. And it really kind of struck me that, wow, we need to get organized and bring people together. So in 2017, everybody knows about CB 5083 ad nauseum. There's lots of publications about it. But there was, from Cleve, there was hope of maybe doing a trial or something like that. But, certainly, there was no registry. We didn't know where all the patients were. There wasn't any funding. And even the FDA wasn't really familiar with the burden of this disease. So in 2018, we started Cure VCP Disease. Didn't know what we were doing. But it wasn't really until late in 2018 at the American Neurology Association conference, and you see a picture of Chris here. Chris was hanging out with us, that he helped us get a table at the ANA meeting, and Jeannie and I, Jeannie, say hello, had a table. And we were just trying to evangelize a little bit about VCP. We, again, didn't really know what we were doing, didn't have any materials, nothing. But the reason I show this picture, it was Monday Night Football of that conference, and my buddy had tickets. We took Chris to that game, and it really sunk in how it's not about what the doctors bring to us. It's what we bring to the doctors. We have to help. We have to help you. We have to build a community around this. And so rather than just looking for something from Chris, it was how do we become friends with all the doctors to bring something to y'all. So that's why I show this picture. So, all right, so Cure VCP Disease 2018, our mission, unite and fund research, building collaborations, building a community. We do have a patient registry. We've got 150 plus in it. I literally just got an email in 12 countries. We're going to add a 13th country. I got an email yesterday morning from somebody in Greece. So we'll be reaching out to them. So board of directors, so Allison and I, Allison, we're both volunteer leadership. Everybody's met Zollie, paid leadership. Brandon, one of our board members, became paid leadership. And then our board, Amy, raise your hand. Yeah, sorry. That's the low question. Sarah Burr will be here at the conference. I think she's coming tomorrow. Kelly, I think, is out of the country right now. Maureen, where are you? Maureen's over there. Dr. Han Fan, she'll be presenting on Saturday. She lives in Atlanta. And then Jesse Vargas, who actually worked for Cleve for many years, is on our board and was unable to attend. And then I do want to thank our board emeritus members. So Sujata, that's here. Yep, there's Sujata. Jeannie, one of our former board members. And I don't think I'm missing anybody else. All right. So thank you to our leadership team. All right, so this has been an 8-year journey. I'm going to blow and go. So the registry was the most important thing we created. We have to know where patients are, right? We have to be able to help. We did our first conference in 2019. We did our FDA listening session. So again, the FDA didn't understand the burden of the disease. We presented to the FDA back in Cinco de Mayo of 2019, on the burden of the disease. Our first natural history study, we started in 2021. What does that say? VCP our first scientific conference was done virtually. So a lot of you, it's wonderful to meet you in person. It seems like we all know each other because we see each other on Zoom all the time. But yeah, so that was our first one. And then CZI, we were funded by the Chan Zuckerberg Rares One initiative. Things are moving. What's happening? Okay. Standard of care. So it's probably Allison led. A lot of the clinicians that are in this room supported that. It's probably the most important thing we've done is putting that standard of care out there. We have iPSC lines, 2 human-derived iPSC lines. For all the researchers in this room, you're free to reach out to us about those lines. We have a biorepository. We're doing a lot of biosample collection. That's another way we feel like we can plug ourselves in to help all the researchers in this room with biosamples. And then Informed DNA, our genetic testing. So, this is a hereditary disease, families, it affects families. How can we help families with genetic testing, or most importantly, genetic counseling? The genetic testing can come later, but that genetic counseling. So we do have a formal program on that. Natural history study was published last year, and then transfer of patient registry to Matrix. We moved to a different platform, and then isogenic cell lines. And then, Dr. Benatar is over there. We're going to have an exciting announcement about the CREATE consortium that we're participating in, as well as Jordy's retrospective study. So we've been published 8 times. One's coming out, the 8th one's coming. But, we believe in bringing everybody together so that we can contribute to the science of this disease. All right, so our roadmap, I'm not going to touch too much on this, but, patient-driven, collaborative, collaboration's the word we say ad nauseum. We will fund some research, but we're trying to find those holes where we can plug in and help what's best, especially from the patient side. And then patient support and education, we do a lot of events like that. So Chris and I were talking about AI earlier. Everybody can roll their eyes, boo, hiss, but there is, there's some neat things that we can do with AI. We've got to be smart about it. It's going to help accelerate the science. Look for us to be doing things and trying to partner with others, especially around Claude Science and some of these tools that are out there. But we understand the risks, we understand the concerns. But you might be surprised, that VCP journey tool for our patients, I'd encourage you to take a look at it. If you want to know what's on our registry, this provides a very interactive way to look at that. So we'll provide those links later. Oops. Okay, I think, so this is 8 years of bringing either scientists together or patients together. This is the first time we're bringing everybody together. So these are from past events, and we really appreciate you making the time to join us in Atlanta. I understand for everybody in this room, scientists, funding's at a premium right now, money may be at a premium, you've sacrificed to come here. For a lot of the PhD and students, you're fighting, every day. I appreciate you making the sacrifice. For patients, care partners, listen, I understand it's a battle to get here. Thank you. Thank you for coming. So I do encourage you, if you're going to be around on Saturday, barbecue, brews, and bingo. This is how we fund a lot of the work that we do. You can win $1,000 at Cash Bingo. You know, we're giving a lot of stuff away at the event. So thank you. So I want to introduce Dr. Zollie Yavarow. She's our Director of Scientific Education, Scientific Engagement and Collaborations. She's a PhD from Duke University in pharmacology, and she also has a master's in bioethics from Duke. So she's been with us coming up on 2 years, and we appreciate all that she's done to help put this together. So help me welcome Dr. Yavarow.
Hello, everyone. My name is Dr. Zollie Yavarow, and I am the Director of Scientific Engagement and Collaborations here at Cure VCP Disease. It has been a lot to come into this room today, so I want to start by taking a deep breath together. In, and out. Thank you, because I needed that. So welcome to the 2026 VCP International Scientific and Community Summit. As Nathan said, this is our first time gathering our scientific, patient, and family community in the same venue at the same time. I've been here for nearly 2 years now with Cure VCP Disease, and my onboarding was literally watching the recorded sessions from the conference in 2024. And we are here today to continue that conversation. When I was thinking about how to design the 2026 conference, I really wanted to focus it around conversations and bringing new ideas to the table and how we look forward. I really strongly believe that one of the most important things we can be doing is engaging with each other and collaborating. So I've structured this conference around conversation. So every session has a panel discussion at the end, and we have a research roundtable Saturday morning as well, and a poster session with some breaks built in. We also have a really full packed schedule. But it was such a wonder to see people talking over breakfast and everybody catching up and everybody who knows each other already. So I'm so excited to hear every single incredible research update at the conference today, but also what I want to see is everybody talking together about what the field needs. And why does that matter so much? Look around at our patients in the room. We don't have a cure yet. We don't have an answer. We don't have a lead target. We don't know exactly how this works. I need all of the brilliant minds here today talking about how we best advance the field forward and what we need and what is going to be the best strategy to treat VCP-associated multisystem proteinopathy. There are a number of things that came out of our 2024 Scientific Summit. First, some real shifts in how it is that we think about VCP-MSP. So we had this sort of old binary thinking of this is either a gain of function or a loss of function. We either have too much activity or too little. And one of the things that we talked about last time we all gathered together is that it is just not that simple. It would be nice if it was that simple, but it is not that simple. There's changes in how VCP is localizing in the cell. There's changes in what different cofactors it's interacting with. And these are things that I'm looking forward to seeing people discussing today. There was also a shift in how we think about and present VCP to people who are outside of our community, to potential funders and partners and anybody that we're trying to bring into the space. VCP-MSP is not just a rare disease. This is one gene that is a hub and master regulator in the cell. If we can understand VCP, we can understand other disease states, including ALS, frontal temporal dementia. It plays a role in aging and protein quality control. It is involved in so many different cellular processes. So it's not just a rare disease, as important as our families are. Like, this is important to our broader human population and health as well. It's not just a rare disease problem. And after our last conference, we were really listening to what it was that was said in the room and what we needed based off that, and we built infrastructure. So one of the things we talked about was the importance of iPSC controls. So Nathan mentioned that we created our iPSC lines, and after our last conference, we went ahead and created what's called an isogenic corrected control. Because the genetic background is so important in VCP, and even within the same family, we can have individuals that present with the same, with different manifestations of the disease in the same family with the same mutation, we realized we needed isogenic corrected controls to be able to effectively study the disease state. So we went ahead and created those, and these lines are freely available to our research network for the first file, just the cost of shipping and handling. Let's see. We also realized we needed a biorepository, so we went ahead and created that as well after our last summit. This now has over 1,400 samples from 70 plus participants, including those controls. So we have controls from pre-symptomatic individuals and people who are unaffected by the disease. And we are collecting for our biorepository right now, and we also need people who are controls. So if you are here and interested in participating in research by giving your blood, we're looking for both men and women who are in these age ranges. So you can chat with me or Allison in the back, and we are collecting downstairs for our biorepository. The final thing I'd like to share since our last conference is we have really been working with AI. So I have worked with Claude Code, and I am not a coder by background, but I put together a VCP publication bank that is loaded with 10,000 different VCP papers, including 4,000 full texts indexed. And this is a tool, a semantic search base, to go in and ask any VCP question that you have, and it's pulling directly from full text and abstracts in the literature. So that's a tool that's available for our research network. Nathan also went and put together the VCP Journey tool, which is based on our registry data. We also have a chatbot on our website, again, to go and ask any questions that you have. This is loaded with VCP literature and website resources. We also put together an AI podcast. It's incredible what we can do now. It's even got AI avatars. So when we see new research come out from our field and we want to understand what's going on and be able to share that more broadly with our community, we make a podcast on it. So that's something that we have available as well, and are always interested in hearing about the latest research that you all have going on. On the clinical side, we now have 3 natural history studies in this space. I want to say that again because that's new as of this week. 3 natural history studies. So we have had ongoing our VCP family registry. This now has 150 plus enrolled patients, and this is powered by the Matrix platform. We also have the CREATE Consortium, Natural History Study of MSP, which is an academic initiative characterizing MSP conditions, and we'll be hearing more about this from our keynote speaker tonight, Dr. Michael Benatar. We also have the MSP study at the John Walton Muscular Dystrophy Research Center. This is also newly funded and for patients with genetically confirmed VCP mutations. We've also completed the Cure VCP Disease 2-year natural history study in partnership with Nationwide. And this has now baseline published results on the clinical outcome measures, and we're working on our longitudinal publication right now as well. So many things. And all of this comes together with our incredible research community. We come together for conferences, but we also come together every month for our VCP scientific focus group with 30 to 50 different people, which is a really great way to stay connected between conferences. Now I'd like to just quickly orient you to the day ahead. So we've got a couple more speakers in our welcome session. And then we'll be moving into our core scientific content for the day. So we're starting off with structural biology with Dr. Peter Shen, moving into protein-protein interactions with Michelle Arkin. We're kind of moving our way up. We're starting at the most base molecular level, moving into how proteins interact with each other, thinking about what that means in the cellular pathways. And then tomorrow we'll be talking a little bit more about therapeutics and patient experience. Then our keynote this evening with Dr. Michael Benatar, and then a poster session and reception. So I'm looking forward to having you here for all of that. I'm looking forward to all of the discussion. I hope you'll contribute. Now I'd like to pass it off to Dr. Chris Weihl. So Chris is going to be sharing about the background of VCP disease and a little bit of the history of how we got here. Chris is a professor of neurology at Washington University School of Medicine in St. Louis and has spent his whole career investigating pathogenic mechanisms of VCP and sees VCP patients as well. He's also on our medical advisory board and has been with Cure VCP Disease since the beginning. So we wanted him to open up and give us the background.
All right. Well, thank you, Zollie, and thank you, Nathan. It is fitting that I'm in Atlanta. This is where it did kind of start with Nathan. I don't see Nathan around. Where? Oh, there he is. I truly call Nathan a friend just because of that. Plus, he brought me to my first NFL game. So, and I remember actually at the end of the game, Jeannie and I actually walked back to the hotel. So, so it was a very touching, fitting thing. And I remember the conversations, and one of the conversations that we had was really, Nathan wanted to raise money. They had just gotten some money. They wanted more money, and he wanted to use that money. And he was kind of like, we want to give it to you. We want to give it to research. And I was like, look. I don't have any great ideas for treatment right now. Like I don't want your money. You know what I need is I need more patients. I need to see the patients. And I can't just hang out a sign and say, VCP patients come here to Wash U. I was like, why don't you make a Facebook page? Why don't you do something and get patients? And he really ran with that and created the registry. We created the registry kind of together, what we would want in it. And I would say that I take only credit for that little bit right there because Nathan and his wife ran with it after that. And they often listened to me, but they more than often didn't listen to me. And they have created really an amazing organization. So I wanted to just mention that. So thank you, Nathan. Thank you, Allison. It's been fantastic, the friendship that we've kind of developed. So I'm going to talk about kind of, IBM PFD to VCP disease, and now we've got multi-system proteinopathy 1 through 8. And it really does start, and I fully want to give true credit to Virginia Kimonis for identifying the genetic etiology of this disease. And if you just look at the pedigree there, and I put you can see how different patients by the box, some of them have Paget's disease, some of them have frontotemporal dementia. The ability to actually see the connections in that and to do a pedigree with that, not only in this family, but in multiple families, is truly an amazing thing. And I say that as a clinician myself who sees patients with VCP mutations, and I sometimes miss it because I can't put the family history together very well. And so I can clearly say that I have seen patients who I didn't actually make the connection with their family member because they had such a disparate phenotype. And so the ability to do that, I really do want to give Virginia credit for really starting really the disease etiology. Though I'm saying it started in 2004, it actually, there were reports of this disorder all the way back into the 50s and 60s with people having diseases and seeing the connection between Paget's disease and muscle disease, Paget's disease and ALS and motor neuron disease. And so it had been seen in the literature, but again, Virginia was able to kind of put it all together. And so we called it at that time, and I say we, I wasn't really involved in that, but Virginia named it inclusion body myopathy, Paget's disease of the bone, and frontotemporal dementia, IBM PFD. And at that time, we thought of it as a completely penetrant disorder with kind of 3 variable phenotypes. 90% of patients get some form of muscle weakness, whether that's ALS or IBM. And then they later can develop frontotemporal dementia with about 35% of patients. Some patients can get FTD in isolation, about 3%. Some patients can get ALS in isolation, about 10%. And so it's a disease that has these kind of variable phenotypes. And you hear that in families where they say, oh, this isn't related to what I have. My uncle had, ALS. They didn't have limb-girdle muscular dystrophy. So it makes it challenging to kind of do a family history. But it became clear that there were other phenotypes that we were seeing in these patients, and that IBM-PFD was really an insufficient acronym because some of these patients could develop cardiomyopathy, Parkinsonism, ALS, spastic paraparesis. And this has been demonstrated even more so through multiple papers which have demonstrated genetically that you can see the cause of ALS being due to VCP mutations, sporadic inclusion body myositis. These patients have VCP mutations, CMT, and different types of degenerative disorders all having VCP mutations. And so it really is a very pleiotropic presentation that is a kind of pan-degenerative disease. And so it makes it challenging to kind of wrap your head around, what is actually causing this? How do we have so many different phenotypes? And so another way of kind of approaching a disease is via the phenotype, that is how the patient presents, what they look like. How does one patient look compared to another? And I just told you that that's kind of a huge, broad spectrum. So another way you can do it is by looking at the pathology. And so one thing that is quite unique in IBM-PFD is that patients get degeneration of the tissue that's affected, so whether it's muscle. And so here you can see, I'll do it on this side. You can see, this is not working very well. Can you guys see it? Okay, there we go. You can see this is a muscle fiber, and this is a degenerating muscle fiber with an inclusion in it, and it has vacuolation and accumulation of ubiquitinated proteins. And so I want to put us back at the time in 2004, 2006, okay? So this is where we are in 2006. We have ubiquitinated inclusions and degeneration in the brain of these patients as well as in the spinal cord. There were ubiquitinated inclusions that were present in the CNS. And this is actually a pagetoid muscle or pagetoid bone where there's actually nuclear inclusions, and these nuclear inclusions are ubiquitinated. And so at the time, we have a disease that has many different phenotypes and has degeneration and ubiquitinated inclusions. And at that time, that's about where we stood. We called FTLD-U, which means FTLD with ubiquitinated inclusions, and we had inclusion body myopathy. And this landmark paper came out from Virginia Lee in Science. I remember when it came out. I remember discussing it. This is in 2006, so VCP is identified in 2004. And in 2006, it was found that the major component of ubiquitinated inclusions was an RNA binding protein called TDP-43. And so TDP-43 has two RNA binding motifs and then has a domain that can cause it to potentially aggregate. We call it a prion-like domain or a low complexity domain. And TDP-43 was present in patients with frontotemporal dementia and ALS, not necessarily VCP. We didn't know that at the time. And you can see here that the ubiquitinated inclusions kind of co-localize with those inclusions. And so this is now 2006. And then in 2000, is this 2008 or 2007? I don't know what the paper says. I can't read it. 2007. So then a year later, it was identified that the nuclear inclusions that were identified in VCP that were ubiquitinated were actually TDP-43. Let me go back one. We're actually TDP-43, it's not wanting to go back. Oh, we're actually TDP-43 positive. And so I would submit to everyone in this room, and it's not a race, but sometimes it feels like a race. TDP-43 proteinopathy, VCP, was the first genetically identified TDP-43 proteinopathy. In 2008, in March, progranulin was identified and published. So just if we're trying to elevate where VCP is, it was actually the first TDP-43 proteinopathy. And then subsequently, mutations in TDP-43 were identified, C9orf72, and TDP-43 in other diseases as well. I don't have an exhaustive list. So what we did at the time, we saw that this was happening. We saw that TDP-43 was in inclusions in the CNS. And so we thought that maybe we should look in TDP-43 in patient muscle with VCP mutations. And so this is now in 2008, where we actually looked at TDP-43 to see if there was evidence of TDP-43 in the ubiquitinated inclusions that we saw in the muscle. and really kind of elaborating that now we have a disease that doesn't just have TDP-43 ubiquitin in the CNS, but also in the other affected tissue in the muscle. And subsequently, people have demonstrated that the pagetoid lesions actually have TDP-43 as well. And so what we were kind of left here was that the acronym of IBM PFD was incomplete. TDP-43 proteinopathy we thought was insufficient, and we thought that this needed to be a dominantly inherited degenerative disorder with varied penetrance affecting muscle, bone, and CNS tissue with prominent TDP-43 aggregate pathology, and we thought that that would be helpful in suggesting a common pathogenic mechanism. And we weren't alone in thinking that we needed to rename this disease, that we needed to think of a better name for this disease. And this is a TV show, and I hope that the, I don't know if it's playing. I don't know if the tech guys back there can make sure that it's playing. Is it playing? Oh, thank you. So Royal Pains is about, this is in 2011. Royal Pains is a TV show about a concierge medical doctor.
Wouldn't you agree? Okay, let's discuss why I'm here. I assume it has to do with the Cuban geneticist you saw, Dr. Caceres.
She's put my markers to good use. Dr. Caceres has diagnosed me, Hank.
With what?
Well, the naming board is still haggling over what to call it. But it appears that I'm carrying a rare hereditary mutation in the 9th chromosome of the VCP gene.
Okay, genetics isn't my field, Boris.
It means that one day, perhaps quite soon, my muscles will turn to jelly and my bones will become breadsticks. Fortunately, once the dementia sets in, I'll be too oblivious to mind any of that.
This is in 2011, and this is a time where Nathan is calling me. No one knows about VCP disease. Nobody knows about VCP disease. And I was like, it's in a TV show. But obviously, the point of this is that if you saw in the beginning, you said the naming of the disease is out. Like there's still the naming committee, and so I can tell you that let me go back one. That we also thought the naming needed to be resolved. And so, and the reason was because there were other diseases out there that didn't have VCP mutations that had Paget's disease and ALS and FTD and IBM. And these are two examples. One of these is a paper of Virginia's where she had identified a family that didn't have a VCP mutation but had the same phenotype. And then this was a paper in Germany where they had this. And this actually led to a collaboration with Paul Taylor, who identified that mutations in prion-like domains in 2 RNA binding proteins that look very similar to TDP-43. So TDP-43 is down here. These are RNA binding proteins, H1RNP, A2B1, and A1, where the exact same residue was mutated in each of these genes, leading us to think that there were other diseases out there that could be, that VCP wasn't alone in causing this kind of spectrum of disorders. And the same was true actually for sequestosome. So sequestosome had been identified for years as being a cause of Paget's disease. TPOCD could identify that it could cause ALS. And we were so excited that we actually were able to identify that sequestosome mutations could cause a muscle disease as well. And so the naming committee got together. And the naming committee, I don't know if Michael remembers the phone call, but it was Michael, Paul Taylor, and myself. We were the naming committee. And we decided that we should call this something else, multisystem proteinopathy. And I would say it's an equally poor acronym. I'm not saying it's the greatest acronym, but that's what we decided. And the reason we did that is because we thought it unified what I said. It unified a common pathogenic mechanism around degeneration and TDP-43 pathology, and it allowed for VCP to be MSP1, and allowed for us to identify other MSP proteinopathies, such as H1RNP, A2B1, A1, and sequestosome 1, where we have MSP 1 through 4. And then I don't know if any of you know Paul Taylor, but Paul Taylor is a very visionary, expansive individual. He wrote an editorial, and all of a sudden, we've got tons more MSPs. As a purist, I would say that these other MSPs don't all cause the same, matron 3 has never been shown to cause Paget's disease. TIA1 doesn't cause Paget's disease. So if you're a purist in the definition, these don't. But I think they help illustrate the common pathogenic mechanisms. So that's how we got to kind of multisystem proteinopathy and why we call it that. And I want to kind of demonstrate how the genetics of these multisystem proteinopathies have really helped us understand the disease pathogenesis. And so I'll talk a little bit about VCP. So VCP, as many of you know, it falls in a category of a AAA protein, an ATPase associated with other activities. There are now over probably 100 mutations that have been demonstrated to cause MSP. Many of them reside in the N-terminal and within the linker domain as well as in the D1 domain, and really at that interface. And so structurally, we're going to hear some great information about kind of structural. Oh, 3 minutes. Oh my gosh, there's no way. And so I will blaze through a little bit, but VCP, as we see here, is a motor. There's been evidence that VCP has an increase in activity, and Andreas has shown that there's an increase in some full-dose activity. I'm going to skip through a bunch, really to kind of get to the take-home points, which is that what we think is going on in VCP is that VCP is responsible for segregating ubiquitin-dependent processes. And so VCP, through a variety of different cofactors, can actually do different processes. And so depending on what it interacts with, it may send something to the proteasome. It may interact with some other cofactor and actually send something to autophagy. And so the importance of that is that we believe that it's actually due to a deficiency in likely a subset of interactors. And so what we've demonstrated, because what we can see here is that with Hemo contacted me and said that he'd identified that cavelin-1 didn't seem to bind to the disease mutations along with a protein called UBXD1. And he actually contacted me because in our mouse paper, we had actually put in a figure that showed that we saw that cavelin actually didn't make it to the muscle membrane. And when he called me, I kind of said, well, I just threw that in there because I didn't really understand it. And I went back and actually looked at the figure more carefully. You can actually see that there are cavelin-positive vesicles that never made it to the membrane. That really did suggest that something was going on. And so what he was able to subsequently show is that VCP mutations that cause disease fail to bind to UBXD1 along with cavelin-1. One thing that is hidden in this, and I point out here because whenever we're talking about gain and loss of function, actually there's a compensatory increase in the association with UFD1, MPL4, and even P47 at the consequence of perhaps a decrease in the UBXD1. And we never really address that, but does that get at this kind of gain and loss of function? And then in patient tissue, we actually see this accumulation of enlarged kind of late endosomes and cavelin positive. And so what we've learned a lot just from that study and from thinking about it is that the mutations in VCP likely lead to a loss of interaction in a subset of cofactors that then lead to a loss of function of a variety of different processes that focus around lysosomal dependent processes. And Hemo's even gone on further to actually delineate this process of lysosomal damage response, and that it's important for VCP to actually be involved in actually maintaining the homeostasis of a lysosome that gets damaged or penetrated in some way. And that's through a complex of VCP, UBXD1, and PLAA. PLAA is another cofactor that doesn't seem to associate with VCP disease mutations. And so this process here is defective in the setting of VCP disease mutations. If we start thinking of MSP as a disorder of lysosomal quality control, we can actually start to understand all of the different processes that we think are dysregulated in VCP, and even go a little bit further and start to think about other processes that have been implicated where inflammasome activation can happen in the setting of lysosomal damage, and proteopathic seed aggregation and escape probably happens through the lysosomal pathway. And so one thing that's always kind of bothered me was the thought, well, I don't understand why we don't see MSP in patients that lack UBXD1 or lack PLAA. I don't understand. That doesn't make sense to me. And these papers came out, which actually show that PLAA mutations actually lead to an infantile onset leukoencephalopathy. Leukoencephalopathy, for the non-clinicians, is just a generic term. It just means white matter disease. It's actually shown on the MRI. There's actually no pathology done on these sets of patients. But what they did do is actually showed that the PLA mutations that cause disease actually don't bind to VCP as well. So now we've got the synergy happening of both of them happening. And so I think, you know, as we continue to do more genetics and start to understand the diseases, we start to learn more and learn more. And so Zollie's telling me I need to end up here, so this is a good stopping point for me. I just want to go back and just let you know that the idea of having multi-system proteinopathy has really broadened the way that we can start to kind of think about things. And so I didn't have a chance to talk more about TDP-43. Eileen in our group is going to give a talk on TDP-43. And then I encourage you to reach out to me. So thank you, Zollie, and thank you, everybody. So.
Hello. Perfect. Thank you so much, Chris. Avi, could you advance the slides to the start of the next presentation? I wanted to give a quick introduction. So next, we're designing with the end in mind. And we wanted to be thinking about what it takes to get to a cure. So we wanted to bring in an industry perspective who could comment a little bit on the drug development process and the industry and regulatory and what we can be doing now, how we design our science in order to accelerate approval in VCP. So Dave Penake is an Atlanta local, and he is CEO and board member of Saol Therapeutics and has gone through this process before. And so we're really honored to have him come speak today and give us some advice for how we can do this most effectively for VCP.
Thank you, Zollie. Yeah, so we're Saol Therapeutics. Saol means life in Gaelic. That's kind of the name behind it, but it's the dumbest name to ever put in the United States. So everything we have has like sailboats on it to try and help people understand how to pronounce our name. I'm Dave Penake. I'm happy to be here. We are doing a lot of things at Saol, but one of the things that we're doing is we're filing for, right now, we hope to have approval by the end of the year for the first medicine to treat pyruvate dehydrogenase complex deficiency, which is a rare genetic disease of metabolism. About 1,000 patients in the United States have it. Median life expectancy is 2.7 years, so it's really brutal. We have run through the gamut of a lot of challenges, which seeing what you guys have done and what this foundation and organization has put together is really amazing. So I think some of the stuff you'll hear is like, well, great, we're already doing that. So please, know that that's the right thing. I'm super impressed. The second thing, though, that is really important for particularly the researchers and the families to know here is that I think people think of all of the work, the natural history study, the basic science, to be what launches a clinical program. And then when the clinical program has a success, that's how you sort of get the approval. What happens often in rare diseases is the clinical program is not super successful. You have a really heterogeneous population, different signs and symptoms. We just spent 20 minutes talking about all the different things that happen, in VCP. And so what you need to actually do is lean on the work that's happening now. And so that's what we're trying to do, but we didn't do it as well as you guys have. And so we'll talk a little bit about the things that you could do to improve that. So we refiled and resubmitted our NDA. We should have a decision by the end of, NDA is the new drug application, by the end of the year. The key thing that I want to show is on April 16th, 2013 was the first FDA meeting to discuss the phase 3 study, okay? That's 5 lifetimes ago for these kids, right? That is a very long time. And there are things that I've learned now that, if I were able to go back to people in 2013 and say, what would I have done differently so that it didn't take 13 and a half years? That's what I'm hoping to do today. I think the context around that is like, what does the FDA require? And what is the work that I'm doing that can support the questions that need to be answered, which will undoubtedly come, but we just don't know which ones will come. And so what can you do to make sure that you're able to answer those questions? So the FDA requires substantial evidence of effectiveness. That's the terminology that they use, the legal term for approval. That's done typically one of two ways. There's usually 2 studies that are required, and they're called adequate and well-controlled, which just think of that as like, placebo-controlled study or just a well-done study that then also has a positive outcome. Rare diseases like PDCD, like VCP, will typically have 1 study. And what supports that is confirmatory evidence. Confirmatory evidence is everything that's happening right now here, right? If you are not running a clinical trial, you're generating confirmatory evidence. And that is needed if you have 1 clinical trial, okay? So this is what's required for approval with the FDA. And the FDA talks a lot about confirmatory evidence. What I would say is, for anyone who's a researcher here, the FDA has like a great resource of tools. These slides I hope are made available afterwards, so like people can look it up if they want. There are guidance documents on what confirmatory evidence is and what's required for that confirmatory evidence. I would encourage everyone who's kind of doing this type of work to read these. But here's a slide from an FDA presentation about rare diseases. And essentially what it is natural history, mechanistic studies, cell lines, all these things are types of confirmatory evidence that can be used. But there are a few considerations that are really important. The first is that the data have to be quality and derived from an appropriate source. So one of the issues that we have with PDCD that it doesn't seem to be as much a case here is like, we don't have a great set of foundations historically because parents that wanted to do that started that and then their children passed away and they kind of needed to separate from this. So now we have, as a lot of kids have started to survive on the clinical trials, we're seeing a lot more parents engage and the organizations grow. But you need to have quality data. And so what that means to our researchers has been, well, it was published. It was published, so therefore it's peer-reviewed, it's quality data. What the FDA means is that they want to go to that researcher's office or that hospital and say, I need to see the data. I need to understand what's there. I want to look at the raw information. And I want to verify that what was actually in the publication is true. Okay, that's a different thing. Most of our researchers do not have those data anymore. We've gone through file boxes and file boxes at hospitals. Most of it's gone, and that's been a real challenge. So I encourage you, that's one important piece. The second is, and this is also really important, less persuasive studies require more confirmatory evidence and better confirmatory evidence. Please expect crazy outcomes in the studies if you have a heterogeneous disease that's not super well understood and is being learned about as you go. You will have questions that come out of the studies that need to be answered with confirmatory evidence. So let's make sure that when we're doing that now, do the things that are necessary to help that. We didn't have a lot of great success with that, and that's been a challenge for what we've done. So if I move on, this is what we've shown. We had a pivotal study that was a placebo-controlled study. It was a novel endpoint because we had a heterogeneous disease, so they tried to create a new way to measure function for these specific patients. The ones who had the poorest function at the start did well. The ones that had better function at the start just stabilized, and therefore we missed our endpoint, okay? So the difference was this took a long time because in 2020, our enrollment slowed because everyone was at home. And what we found was that the kids were surviving. And so eventually we went to the FDA and we said, can we look at this? And what they helped us do was we looked at a natural history study out of Cleveland, Ohio. It basically tracked the survival of the kids. We compared it. What the FDA has worked us up, we basically show about a 90% reduction in the risk of death with treatment here. So that's our primary study. But the FDA has questions. Those kids were from the 80s and 90s. Our kids are from, the 2010s and 2020s. And so they're trying to decide, is it maybe genetic testing that these kids had, maybe they're less severe or whatever the case is. So we are doing all the work to show that, but then we need confirmatory evidence to substantiate that. And so our entire approval in December everyone agrees that kids survive longer if they're well matched, but the question is, are they well matched, right? So we require confirmatory evidence to show that. So, what I would say is for us, it's been old, imperfect data, methods that aren't used anymore, methods that could be used, but they aren't well documented. And then we also have a lot of conflicting literature. It sounds like there's a lot more cohesiveness here, and I would encourage you to continue that. But what you want to do is have reproducible information. So if you are a researcher documenting methods, document them well, save them with the data. You want to have an appropriate source for that information that the FDA could walk in the door and say, I'm going to review it. That will help you meet the regulatory quality standard. So if I look at just the natural history, I'm like amazed, like I'm going to go down to the biobank. I think, I'm old enough that I was in one of those bubbles to give some blood. But, use the same validated measures. If you end up clinically identifying a new measure, incorporate it right away into the natural history study. I would encourage clinicians to do that. Videos, patient family survey results, et cetera. Probably the most important thing beyond that is consistency about when you measure things. So, there was a drug named Qalsody that was approved for SOD1 ALS from Biogen. They had really consistent tracking of patients. It was every 3 to 6 months. The patients went into the clinic. The data were collected, all that stuff. Then you have another drug called, I forget the name of the medicine, but it was for Barth syndrome and Stealth Therapeutics, and they recently got approval, but there was like a huge, crazy inertia that had to happen. There were a lot of political interference that eventually, I think, forced the FDA's hand to approve it. I'm glad it's out there. It does look like it potentially works, and they're doing a confirmatory study. But their real problem was that they didn't have consistency about when patients were measured. So some patients came into the clinic every 2 years, some patients came every 3 months. And so they weren't able to actually show the progression of the disease in a way the FDA could compare it to what's happening. So the only way the FDA can overcome something like that is by just running it longer, right? So for us, we've been treating kids for 6 years, and the FDA needs to believe that there's a difference in survival. And without great evidence or great confirmatory evidence, they're just saying, well, let's see what happens in 2 years. Are the patients still living in 2 years? Well, then I'll feel better about it. What about in 5 years, right? And that just takes too long, right? So we don't want to do that if we have the opportunity. So then what about foundational science? I've touched on these. A big thing about the FDA is robustness of the data and the measures, right? So they'll want to see raw data. So if you're doing this research, make sure you save it in an appropriate way so it can be looked at. The other thing is, if you're measuring something and you have a kind of wild type control and then you have a cell line that's maybe a VCP cell line, and they have one measure is 10 and the VCP measure is 200, it's great to show that the range that, when you do that measurement, that 200 is a valid measure, 300 is a valid measure, 0, and test all of those along the way so the agency can say, oh, this wasn't just an aberrant result. They actually made sure that the results are valid. And so a few things like that early on go a long way, because handing the FDA a publication is just not good enough. They won't accept it, right? And if the question ultimately relies on the work that you're doing today, and the answer to the question that the FDA has is in those data, you'll want to be able to, the company that's working with you will want to be able to go back and say, okay, let's go look at these data. The FDA can walk in and take a look, okay? So for me, I would say, these have been kind of really important learnings that I would encourage others to do. It sounds like you guys are on a great path for that. So what does this mean? What I would say is you could have a failed study that works, but you just haven't measured it the right way, and patients are doing better. And if you have the right confirmatory evidence and that's done well, you can get approval. And you can get approval the first time around. And you see that with some of these other medicines that are out there. And so what does that really mean? I think the FDA definitely understands that rare disease is challenging, right? That's why they will approve drugs even though studies miss their endpoints, right? They try and work with you. But they do have legal regulatory standards that are required. And so, from our perspective, there are probably 2 or 3 critical things that could have been done 10 years ago for our disease population. We would have had a medicine 5 years ago. We hope it happens this year, but it's totally plausible that the FDA will say, well, let's check again in 2 years. Let's just keep waiting. That's not something we want to do when that's a lifetime for these children. So I don't think we probably have time for Q&A. I'll be around most of the day. If you have questions, I'm happy to answer them. These are 5 children that are in our study that are doing great, and they're growing up. So really excited to see where we can help and go from there. So thank you, Zollie.
Thank you so much, Dave. Before we move into our first scientific session, I want to welcome Amy Casey. Amy Casey is a board member of Cure VCP Disease and a patient with the disease as well. And so she's going to ground us for why we're here in the room today.
Good morning, everyone. Thank you all for being here. I'm just going to share a little bit of my story and why we're here. Have you ever thought that you would ever hear someone say they wish they had cancer? As someone living with an ultra-rare disease, I have had that very thought. If I did have cancer, people around me would know what I was dealing with. They would have others in their life that have dealt with their disease before. There would be funding to go towards research, large-scale support organizations, GoFundMe accounts, global events like Relay for Life, and other events would be well known. There would be awareness. I don't say this to take away from anybody who has suffered or struggled from cancer. I say this because I'm envious. I'm envious that they have a chance to survive. Growing up, I never knew my dad without the muscle disease that plagued our family. I believe he got his first symptoms in 1978, but it could have been as early as 1972, as on his military discharge paperwork, it stated decreased muscle strength as the reason for his honorable discharge. He slowly deteriorated, and my junior year of high school, he went to live at the Iowa Veterans Home, where he lived for 21 years until he died in 2016. He didn't know he had VCP disease. We didn't get our family diagnosis until 2018, a year and a half after he died. People would ask me what my dad had, and I didn't know how to answer that question. For a while, I said ALS. Then I said spinal muscular atrophy. And then his doctors just said, "We don't know, Mike. We don't know what you have. Just go live your life." So that's what he did. I was initially told that they didn't think that I would have to worry and that females really weren't affected by what he had. Thought I was in the clear. Then I was told there was a 50% chance that I could have what my dad had. That's when the anxiety began. Every weakness I felt made me wonder if I had it, even though I didn't know what it was. At age 37, I began lifting heavy weights. It was wonderful. It was amazing. I felt strong. I loved it. But I could not increase the weight on a military press above my head no matter how hard I tried. Everything I did failed. I just could not do it. I struggled to put my hair in a ponytail, putting things in the cupboard, getting them out. It was hard. Deep down I knew, but I tried to ignore it. Our family got word of VCP disease diagnosis in January of 2018. I was tested immediately. There was a mad dash in our family to get tested because we finally had a diagnosis. There was no advice to get life insurance. There was no advice to get affairs in order. It was just a rush to get a test. Unfortunately, a week after my sister's funeral, I was at work and I got the dreaded call. I had this disease. Until June of 2019, a year later, I thought I was completely alone. My other affected family members that had just gotten a diagnosis were no help. My husband didn't know what to say. My mom had just lost her husband and my sister in a period of 4 months, so I could not burden her. I turned inward, and my life was very dark. Then my aunt, who has since passed away from VCP disease, called me in a panic to tell me about an organization for people like us. It was Cure VCP Disease. I finally saw light at the end of the tunnel. VCP disease is not something that people know about. Because of that, the burden on patients like us is high. It's very heavy. The words "no treatment" and "no cure" echo in our heads. Will I die the same way my dad did? What about my kids? The anxiety of the unknown is deafening. And through all of it, we live. We live life the best we know how. We participate in research. We accept the decline in our strength as what it is, and we move forward. We offer our knowledge and share about our experiences with this disease to as many people as we can. We educate our medical teams who are unfamiliar. We reach out and support each other. We raise money, and we hope. That hope, though, is not passive. There is action behind it. Because we don't have large organizations behind us, we ourselves carry the responsibility of spreading awareness, raising funds, and building a scientific network like you all to help study our disease. I'm grateful. I'm able to tell you a part of this story today because of Cure VCP disease. The patient and family burden here is high, and I am excited that you are all here to see the human side of VCP disease. We are regular people who want to live. We want our families to be healthy and not suffer. I believe I speak for our entire community when I say that we appreciate you being here and that we are grateful for every ounce of energy you spend working towards a cure for us. Because of you all and because of your Cure VCP disease, our chance to survive is growing. As I look around the room at all of you people full of motivation and ideas, I'm proud to be part of this. This community is changing the trajectory of this disease. Because of this group and the hope being acted upon, I no longer wish I had